to relax.
With a little Q wave divot, you mean?
With the S, yeah.
It affect the flow through the heart. So whenever it falls down too low, that means ischemia. When it goes up, that means you have to have infarct. We have actual injury going on. We'll get into that. I don't want to get into that right now. So, T wave, you know, it's the recovery. Okay, we don't measure it. We measure the QT interval, but we don't measure just the Q wave. What electrolyte causes peak to T waves? Potassium. Okay. When I'm talking peak to T waves, this is what I'm talking about. Here's my P wave, QRS. This is my T wave. P wave, QRS, T wave. That's pretty tall, isn't it? Like, that looks like my QRS wave. You'll have telemetry monitors pick it up and say this is 1, 2, 3, 4, 5, 6 beats instead of a 3 beat because it gets so tall. So just kind of keep that in mind as you're going through that. This one, here's my P wave, here's my QRS, this is my T wave. Right? So this is your potassium at 7 or something like that. It gets really, really peaked. So this is when something bad's going to happen to your patient. When you start, if your P wave should look like this, like your T wave, if it starts peaking, check your patient's potassium. That's just a given. Like when it starts peaking, figure out why. Oh, what patients have problems with potassium?
Heart failure.
My renal patients, heart and renal, people on Lasix or furosemide, and renal patients. So watch them extra close. A lot of times they're on telemetry just for this reason. I have a renal patient, they're with acute kidney injury, they're going to be put on telemetry, a lot of times because of the potassium levels. I got to keep moving. You just hold your questions, make a list of questions. Okay. All right. QT, I'm not going to make you measure this one. Did you know that there's sometimes a U wave? Okay, U waves, we don't mention it very often. There's certain conditions that can create a U wave, and some people just naturally have a U wave. We don't measure it, we don't count it, we kind of ignore it unless you work in the cardiac unit. Then you can worry about that. So right now, forget that ever existed for this class. Right. Just back to here. So if I was taking, here's my paper, and I need to take your calipers. You need to take your calipers if you had. Here's my PR. I don't know why. PR interval right here. So I'm going to start measuring it, and it is how many boxes? 1, 2, 3, 4 and a half boxes. So I know my PR interval is okay. That's basically what you do. If I have my QRS, how many boxes was that? 2 boxes. Is that okay? That's in 1.5 to 2.5 boxes, so we're good. So it's a narrow QRS. Sweet. I talked about the 6-second thing that's going on here. So basically, here's my 6-second strip. I need to count in between these divots how many peaks I have, multiply by 10. That's my heart rate. So if you're doing a quick glance. 1, 2, 3, 4, 5, 6, 7. 7 times 10, that heart rate is 70. That's easy. You're like, that's the easiest thing you told me all day. Yes. All right, so what's this one? 14? That's 140. Is that what you guys said? I think I counted 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. 140. This one?
I would count for a full minute.
First time around. 70. Oh, hey, why don't I do another one? Okay, now I'm going to show you here. This is my starting point, so don't count before here. I'm just going to here. So just count in between these 2 larger ones. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. That's 120. Everybody good there? Now we're going to do the rhythms, because that's the fun part. That's where you can like look and be like, oh, they're in AFib. Oh, they're in VTAC. Like, what else does that mean? So, we'll look at the rhythms here. Okay, generally speaking, if you ask these questions It'll give you all the information you know to determine the rhythm. There's a lot of rhythms you're gonna look at and you just know. But there's rhythms you gotta go through the questions with. You wanna see like, okay, are there P waves? Some rhythms don't have P waves, so you wanna see if they're present. Yep, okay. Is the QR complex, is it narrow or is it wide? That's gonna tell you a little something. So you wanna look, you wanna measure that. Is it narrow or wide? Step 3, the PR interval. Is that, what's the range for PR interval again?
1, 2, 2.
0.12 to 0.2, 3 to 5 boxes. Absolutely, so I want to make sure that's in range. If it's not, that determines something. Do I have more P waves than I have QRSs?
No.
Meaning, I should have one P wave and then a QRS after it. One P wave, a QRS after it. If I have a P wave, P wave, P wave, then a QRS, P wave, P wave, P wave, then a QRS, that's something wrong. So I need to make sure it matches up, a 1 for 1. So I'm looking at that too. I'm gonna look at my rate. Is it 50? Is it 180? Is it 20? You know, like what's my rate going on? And then I want to know if it's regular or irregular. Regular means, let me throw up this one here. This is a regular rhythm. This is your normal sinus rhythm. If I measure here, this should be always the same distance. That gives me a regular rhythm. If it wasn't the same distance, if some was this, some was this, some was this, that's different distances, and that's called an irregular rhythm. When you palpated their pulse, it'd be like dun 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 dun. You know, it'll like make you feel weird, like your own heart can't beat right because it's off rhythm. And so we're looking for that. Oh, so normal sinus rhythm, everything. If you answered all of those 5 questions. Let me write those questions on the board here real quick. Which side can you guys see the best on? This side or this side? Either.
Can you not use the blue?
Yeah, I have black now.
Okay, cool. Sorry, it's just hard.
So I want to know if there's P waves. So we'll look at all of these. I want to know if my QRS is wide or narrow. I have some of this on your homework for you too. I want to know my PR interval. I want to know, do I have P to my QRS? Is that equal? And I want to know my rate. And I want to know if it's regular or irregular. Okay? So those are the things we're going to look for each of these. Okay. These are sinus rhythms. Sinus rhythms are rhythms that come from my SA node. These are all rhythms that start here. You have rhythms that don't start here, so we're talking our sinus rhythms now, and it's pretty straightforward. Normal sinus rhythm. Do I have a P? Yes, I have P waves. Do you have a P wave with a QRS after it? Yes, all of my P waves have a QRS after it. Is my QRS wide or narrow? Narrow. Yeah, if you measured it, it would be just tiny. It's just one box. Okay, so I'm less than, I'm in range. What else is going to ask? What else is my list? I want to know, do I have a PRS for every Q? Yes, and I want to know what my rate is. So, ooh, man, going the wrong way, Nance. My rate, 1, 2, 3, 4, 5, 6, 7. My rate's 70. And so my rate's normal. It's in the normal range. So this would be a normal sinus rhythm if everything checks out as far as that goes.
Didn't you say that it was a narrow QRS?
That is a narrow QRS.
But it's still normal?
Sorry. I'm about 1.5 boxes. I didn't go the whole way over here. I should have. Does that make sense?
Do they do this in real life, or is there like it's something online?
They do.
You can do it online, but always double check because it's not always right.
Okay.
A computer will read it to a degree. And then there's other times you need to check it and read it outside of that.
I know
It
sometimes you
depends.
can click and drag and rotate the distance, or if you have like actually put
You
those.
can do that, yes,
Okay.
if you have the computer access to it, absolutely.
Okay.
Click and drag and check it. That's nice.
Did you
Usually, you get to the point where you can just look, you're like, oh yeah, that's 2 boxes.
Okay.
And
Did you
just
say
do it quick.
sinus means it originates from the SA node?
Yep.
So sinus. Okay.
Yep, sinus means it came from the sinus node,
Okay. Thank you.
the original signal. That means this thing just fired 7 times and 7 signals went the whole way through. Sinus bradycardia. You okay, Liz?
Yes, sorry, I was asking.
No,
Did
you
ask
sound
me a
confused.
question?
Look, I just want to make sure.
No, I'm thinking about something that she just asked.
Okay.
Me, not related.
Now,
I mean, it's related.
Vivian, you can't ask other people either. Zip it.
Sorry.
All right. I'm gonna look at my PR interval. I'm gonna rate my PR interval right here. Okay, we are less than 5 boxes. I have 4.5 boxes, so I'm happy there. I'm gonna do my QRS measurement. Right, almost 2 boxes there, so that one's okay. So I have a narrow QRS. My PR interval's okay. I have a P wave present. For every P wave, I have a QRS, P wave QRS, P wave QRS, P wave QRS. So I like all of these things right here. What's wrong? My rate. So you do your rate 1, 2, 3, 4. So everything looks normal. Everything looks like it came from the SA node, except my rate is slower. And so this would be sinus brady. What's your normal heart rate? 60 to 100. So anything less than 60, if it looks exactly the same as a normal sinus rhythm except for rate, it's going to be sinus brady. So that would be a sinus bradycardia. It should look the same otherwise. Same thing here. Okay, let's go through here. Do I have P waves? Yes, I have P waves present. Is my QRS wide or narrow? Let's measure it. Oh, it's just 1 box. So that means it's on the narrow side, all right? I've got a narrow QRS. My PR interval, 10. This looks a little different, so let's measure that. Okay, it's still less than my big box. It's at 0.4, it's 4 boxes. So that's okay. My PR interval is still good, yeah.
The narrow, like, how many boxes are we looking for again?
I said 1.5 to 2.5. It's usually around in there. It might be 1 to 2 boxes. I'm not measuring real exact, but yes, 1.5 to 2.5 boxes. So I've got that. My PR interval's okay. Do I have a P wave? And for every QRS, yes, I do. Don't worry about these other bumps. What are those extra? That's just a T wave. Okay, you go through it. P, QRS, T, P, QRS, T, P, QRS, T. Don't think that, ooh, that's a weird thing. That's, you have equal number of waves, exactly what you're expecting. Okay. Now I'm going to look at my rates. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. So what's my heart rate? 130, absolutely. So everything looks normal except for my rate. I want to know now that it's 130, I want to make sure it's even. From here to here, is that the same? Yeah, it's the same. And so my rate is regular. So this would put me in the range of sinus tach. So those are your 3 easy ones. Normal sinus rhythm, sinus brady, and sinus tach. So one's lower, one's higher.
For the QRS, when you're saying it's wide or narrow, if it's narrow, it's gonna be closer to 1.5, and if it's wide, it's gonna be closer to, or not 1.5, but like.
It'll be bigger than 2.5 boxes.
It will be bigger?
It'll be even bigger. It can go bigger. That's the good healthy range. When it goes wider than that, it came from somewhere else.
Okay, so just staying in that range is a normal.
Yep, yep. Anywhere in that range is normal range. Yep. Do you guys want calipers now? Like, if you have it print, I mean, it's probably too small to print right now. If you want calipers, you can have a caliper, but we can worry about it later. Maybe for homework assignment, you can take some calipers with you.
Wait, what is the measuring thing that you're using?
Uh-huh.
Oh, okay. It's a compass, right?
Caliper.
It's not a compass.
Compass measures angles. I'm not measuring any.
No, it's not a
It
protein.
looks like a compass. It doesn't have a pencil on one end. Okay, guys, if you don't know, okay, if you like, I don't have those fancy things. Y'all have a piece of paper. You take your little piece of paper, whoopsie. You take your piece of paper, you hold it up here. Oh, this is here to here. All right, here, here. Now you can take that thing and go from here to here to here to here, and so it's even. That's your cheap way of doing it. It doesn't have to be a fancy little device. Sometimes you can't find the fancy little devices. Or computers will measure it for you. We like computers. So this is sinus tachy as well. I just wanted you to see the difference. This one, man, these are starting to bump together. These, I can see a little separation here. I like how this, but it's still there.
So what's this, so then bumping together, what that causes?
It's not going to cause a problem. It's just harder to read it. And I'm going to show you where it's going to be a different reading. I don't care if the P wave hits my T wave. I just don't want my QRS to hit my T wave. We're okay still. It's getting a little closer here. And this one, it's a little bit closer here. It's less thing, but it's still sinus tach. This is still sinus tachycardia. Do you guys think you can identify those? Any question? Yeah. So that's you've got 3. You know 3 rhythms.
Know us.
Look at us.
Look at you guys go. All right, 3 rhythms down. Sinus tachy, I will tell you there is actual range for it. A rate range. When it gets higher than that, they call it something different. Sinus tach is from 0, nope. It's from 100 to 150. So sinus tach is 100 to 150.
The 101 or
You can go 101. I mean, it's just relative, right? On a test, I'm not going to ask you like, it's 10, what's 100 exact? I'll leave it into it. Right. You're not too symptomatic at 120, 110, 115, but we'll talk on Friday or next Wednesday. We'll talk about what do we do about each of them, whether we just watch it, whether there's nothing to worry about, or whether we, that one pay attention to. Yes. All right, so here's your range. Here's your little table with ranges in. So here's your range of C, 101. I did get it right there. Now, we're going to talk about rhythms that come somewhere. SA node, AD node, the bundle, and then my right and left, and my hinges. When I'm talking atrial rhythms, it's just saying the rhythm came from somewhere in the atrium. It didn't necessarily start here. It started somewhere else. It can be the SA node, but it can be somewhere else. So it's somewhere in the atrium the starter cell was. That's all it's saying. Yes. Okay, sorry. We will get there. We're not going to confuse them yet. You're okay. They can all go to you whenever they're ready to study. All right. What's up with my, and you're allowed to interrupt me today, Heather, because I took your computer away. If it comes somewhere else in the atrium, here, I want to talk about a PAC. A PAC is an extra atrial beat, right? If I look at this, you're like, oh my goodness, you just lost me, Nancy. It's not regular. If I look, I want to see, do I have P waves? Yes, I see some P waves on there, right? Check that one off my list. Is my QRS wide or narrow? You all can tell that. My PR interval, let's look at that puppy. Is my PR interval, does it look okay to you guys?
No.
My PR interval is here. Well, that's 4.5 boxes, 4 boxes, somewhere in there. Here's my PR interval. Here's my, that's weird. Okay, that was a weird one. We're leaving out a weird one. Weird one. Okay, this is a weird one. We got normal. Okay, here, cut it down. All right, okay, that's bad. We go way beyond the normal. What's happening here is I have my SA nodes firing. SA nodes firing. Cool. SA nodes firing. There's something going on in my heart. One of the other cells decided to jump in. So this is firing. I got my normal complexes firing. Now all of a sudden, another cell decides to chip in randomly. So this one's going, this one's going, this one's going, boom, an extra one hopped in. This one's going, boom, another one hopped in. It's called a pre-atrial contraction. It happened before the normal SA node wanted to go. It jumped ahead of the gun. If I'm marching this puppy out, boom, this should have been here, but he jumped in ahead of time. It's like, I'm not waiting for you, SA node, I'm going on my own. Going rogue. All right, but then it'll come here, should have been here, here, here. Oh wait, this should have been over here and it came early. So you're looking for it to come early. It will look like your normal rhythm bump, but it just is earlier in the process. This one I can't really see. I have a little bump here. That's actually my P wave stuck in here, but it just came earlier. Everything else looked the same. Right? So when I'm talking about this one, I'm going to call this a normal sinus rhythm with PACs, because everything else is normal with it. So it's a normal sinus rhythm, but it has some extra beats in there. That usually comes from something like lack of oxygen to your heart, or too much caffeine, or stress, or not enough sleep. It'll cause you to have some PACs going on in there, all right? So you probably have them now already. Anybody ever feel like the heart jumps a little beat? Yes. You might be having PACs or PVCs.
Is this the thing where that some athletes have, like where it sounded an extra beat?
I don't know what you mean.
When I was in high school, I had my friend's mom was an practitioner, she's my physical, and she said she could hear like an extra little.
A beat, yeah, a beat,
and
yes.
she said that a lot of the young athletes have that.
Yes, yes,
Is
that's
this
what this
that?
would be.
Okay.
It'd be this or PVC, and we'll look at those in a second.
Okay.
Either from the atrium or ventricle, whichever part's angry.
Oh, side effects, right. Like, are you gonna put us on that, like, for this, we need to know that stress can cause it?
I'm gonna go over that the next day. We're not getting that. I don't want you to have to worry about that today. So don't write, you don't have to write that. That's all in another PowerPoint. It's all laid out for you, everything. Sorry about that. I just sometimes I'm like having, I can't help myself. I just want to give you more information. But you can write it down here if you want to. So this gets a little harder to start reading. All right, so people look at this and they are, what's going on? But if you just look, what's your underlying rhythm? That's when you grab your little calipers, grab your thing, or look on your computer, and it will say whether it's regular or not. This one's pretty easy. Like right in here, it should have been right there, but this one just came early. So all it's is extra beats that came early. It's before it should have come. And it came from another location. Because if it came from here, it would have been firing the same way. Here's another example of it. Okay, here. Oh, it came early. Should have been. That one just came a little bit earlier. I felt it anyway, and it's narrow. It came through.
Get me up with that thing.
It's my little marcher. Sorry. Do you want me to put that away? Is that annoying?
No, it's fine. It's so funny.
Boom, boom, boom. Emphasizing my point.
Look at my pencils. Look at my pencils.
This looks just like what? What did we already talk about that this kind of looks like? Looks like sinus tach, but it's faster. So if I go above 150, so 151 or higher, I'm going to call it atrial tachycardia. As long as I can still tell there's a P wave somewhere. So as long as I can you tell there's a P wave in here? It's stuck in there. So it's P wave, QRST, P wave, QRST, P wave, QRST. So there's still a P wave there. It's just kind of starting to jump into my T wave there. Here's your rate general range, 150 to 250. As long as I still see a P wave, I know it's atrial. If I don't see a P wave, I call it something else. And I'll show you that in a few minutes. So, same thing, P wave for every QRS. It marches out nice and even. It's just faster than 150. Right? Ready for me to go on? All right, kind of, sort of. Here's another example of that. Can you still see your P wave?
Barely.
Barely, I know. It's getting up there. The rate's up there. Does anybody want to calculate my rate? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18. So that's 180. So as your rate gets higher and higher, it gets harder and harder to see my P wave. But I can still tell it's P wave, so I still know it's somewhere in my atrium. I'll have a P wave that's in my atrium. I just can't see what it looks like. Oh, the AFib. Right. It's everywhere. Oh my goodness. If you look at your monitor in every hospital you guys go into, somebody will be an AFib. It's just the standard. It's the most common dysrhythmia besides tachybrady. It might even be more common than that. It's everywhere if you're AFib. Okay, we've got to run this thing through here. Do I have a P wave?
Which one is this?
Which one? That's exactly right. All right, this whole wiggly line here, these are all different P waves. Oh my goodness. No, I'm not gonna make you count them. I don't care. There's probably like 300. I don't know, there's probably 30 along here to give you a rate of about 300. So these are all little P waves along here. And so it has multiple P waves, but I have a P wave. Does it have a QRS?
Mm-hmm.
Is my QRS narrow or wide? Well, let's measure that thing. It looks a little funny, doesn't it?
1.5 or 2 bucks?
I can't tell.
That's just under 2 boxes. So is that okay?
Yeah.
Yep, okay, so it's still narrow. Okay. What's my PR interval? Can you measure it?
No.
No, there's just too many P waves. You can't, it's nothing measurable. So there's P waves present, but I can't measure that. So this one we don't even worry about here. Do I have a P wave for every QRS?
No. Yeah, at least one.
You have more P waves than QRS. It's not equal. Okay, so write that down there. And then what's my rate?
Right here.
This one's at 100.
And it's a regular.
When people have AFib, if it's uncontrolled, it tends to be over 100. If it's controlled, it'll be less than 100. But most AFib patients, when they first go into AFib, it's usually well over 100. Just kind of keeping that in mind.
Are there multiple P waves from the SA node plus a whole bunch of other cells firing?
Yep. It might not even be the SA node at all. We can't really tell. And so in this case, what's going on? Because here was my PAC. Think about a whole bunch of PACs going on at once. So either my SA node isn't working anymore, or it's working, but there's a revolt. And all the other soldiers here, or all the other cells, like, I want to be in charge. So everybody, like, I can fire, let me. And they all fire at once. They hit their signal. And all these signals are going all at once. Boom, 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 boom. So for every one of these, it's hitting a signal. The AV node is like, whoa, that's too many. Not that many can fit through the crowded door. I can't send that many signals through. So every once in a while, all these signals come through, causing this wavy line, but then a signal will get through. The AV node is like a gatekeeper and will only allow so many signals through it. Thank goodness. If it's not controlled, it might it might get a rate of 180 or 220. But depending on how many signals go, how fast that rate is, that depends on how symptomatic your patient will be. If it's on medication, if it's well controlled, if it's at 80, people can live in AFib just fine. They don't feel as bad. Everybody will depend a little bit different based on that.
What did you say the rate was
For AFib, it varies. If it's uncontrolled, it's over 100. If it's controlled, it's less than 100. Yep.
Are you going to tell us what causes AFib later? Okay.
I sure will. It's usually an MI, by the way.
Thank you.
Anything else? Oh, so what happens here? All of these are sending signals all at once. Do I get a good contraction? No, it can't go hoompa, hoompa, hoompa. It'll go ee and just jiggle and wiggle. And that's where the clots come in. So your AFib patient, they're the ones at risk for clots because this is jiggling and not squeezing it out. In AFib, this valve right here and here will open. This usually squeezes and squirts it out down here. Now this will open up and it'll drip down in, but it doesn't squeeze it in. And so it loses a little volume that drips in. Think about it like you have a bucket of water. You put a washcloth in it and you pull the washcloth up and all the water drips down. Okay, I pick up my washcloth, the water drips down here. If I take it and I wring it out, I get more water. In AFib, I don't have that wringing out of the washcloth. So some blood gets down, but not all of it. So it doesn't have that squeeze to wring it out.
So is your blood pressure lower?
Yes, maybe. It depends. It will depend. Sometimes you compensate. But if it's so volume low, then it can't compensate enough. So it depends. Here's 2 more examples of AFib. I've got, and then I have a QRS that's narrow. Wiggle, 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 QRS is narrow. This one, it's probably my T-wave here. I can guess, I can't really tell. It buries it in there. But it's all in there together. This one, okay, this is more typical of what AFib looks like. I will tell you, I didn't go down my list. The rate goes up. I will tell you, it is always 100% of the time irregular. 100% of the time, it will be an irregular rhythm. I can't march it out evenly. Always irregular. I'm gonna grab my big old calipers again. Okay, big old calipers. Here to here, here to here, here to here, here to here. It's not even. And so it will always, always, always be irregular. Here to here, oh, should have been there. Nope, okay, this way. Oh, nope, like it's never regular. Because, does that make sense though? Because it comes from different areas. And so it's going to choose to let certain ones through and not other ones. But that's typical AFib straight up. If you can recognize it, fantastic. I think anything else I got here before I take a break. Let's do atrial flutter and then we'll take a break. Okay? Somebody's got to pee. Everybody always has to pee. Yeah, we're all tired from atrial flutter is very similar, going to have similar symptoms, going to have similar rates. But atrial flutter just looks a little bit different. Okay, similar thing happening. Okay, SA node, AV node. This is coming from not the AV node. I mean, it's not from the SA node, it's coming somewhere else. And so usually, they look kind of consistent. Usually in atrial flutter, my P waves look the same. What happens, you get in a weird loop. And there's like it's a recircuiting, it's like a wire shorting out almost, all right? So I might have a couple cells right here that are like really irritated. Irritation comes from things like lack of oxygen, caffeine, scarring, MIs, things like that when we talk about irritation. This is irritated, so we start sending a signal. Well, my signal comes back around here, makes it fire again. Comes back around, makes it fire again. This one isn't firing at all. This one keeps going around again, 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 again. Oh, that's a signal through. Again, 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 again. But it's from a single or a limited location. So they look like it looks like a saw or waves. It looks like a sawtooth type thing that's going through there. Does that make sense?
What's the difference between flutter and fit? Different spots versus one spot. Got it. Sorry.
Yep. All right. So the flutter waves, now sometimes you think, wait, isn't that a T wave, QRS T wave? Well, there's extra waves in there. Sometimes if it's going fast enough, it's hard to tell. But you'll see it's like a sawtooth pattern that's consistent throughout. And we'll have some practice ones to look at. But atrial flutter, I don't know, it's like, I don't know how you can, I don't know. I'm trying to think of how you remember. Well, it has an F in it for flutter. No, atrial fibrillation has an F in it too. But didn't it? Huh?
Hummingbirds?
Sea waves?
Yeah.
Oh, like the sea. Oh, you're fluttering on the sea.
I think
Oh,
hummingbird
and you're
is
fluttering, floating along in the sea. It looks like you're, I like that. I'll use that from years on out. Oh, is that a Kira?
No. She said, bird.
Yeah, I said hummingbird. It's just
A hummingbird. Flutter, butterflies, yeah. Oh, they float so nice. Here's just more examples I wanted to show you. If you look at this, you think, oh, but isn't that the T-wave, P, QRST? It looks like it, but be careful, and that's why it makes it hard to tell. That's why you kind of go like, well, maybe. Do they have other symptoms with it? What's my rate? It tends to be fast, it tends to be irregular.
Sorry, I was just saying the way you tell the difference is because most of the time with AFib, it's smaller and almost looks like there's nothing maintenance.
Yeah, yeah.
Whereas here it's a little more.
Right, right, absolutely, absolutely. I'm just saying how you can besides normal sinus rhythm in this, some people confuse it. Because this one, it's like only 2 waves in between. It's a faster rate, so. You're looking for it, the shape of it just a little bit, see how it like angles forward? This is another example of it. More examples, you gotta look and see, the better. All right. Okay, this one I can't tell if there is a P wave or not. So if I can't tell if it's a P wave, I call it SVT instead of atrial tachycardia. What's my range for sinus tachycardia? 100 to 150, or 101 to 150. All right. Atrial tachycardia is what? 150 on up. And then what's present?
P wave.
And it has a P wave. If I can't find a P wave or I'm not quite sure, then I just call it sinus tach. Sinus tach several things can be sinus tachycardia. So it's a fast rhythm, it's anywhere from 150 up to 300 in that range.
But this is still an atrial rhythm?
It's still an atrial rhythm. I know that because my QRS is narrow. If it's from the QRS, it's up there. Atrial or junctional, I haven't talked junctional yet, so I'll throw that in there, in the side note. It's not from the ventricle, it's from above the ventricle somewhere. All right, go ahead and take a break. Sorry. We started a little late, so. If it's one, we don't get, I don't know how far we got. If it's one we don't get, don't do it.
I would never leave this for my notes. I would literally never leave.
Making sense so far?
Yeah, very good.
I have a beautiful brain.
You're ready to jump on. Your brain thinks
It's so spring.
But, okay, here's the
You're
thing.
taking
I
that hemoglobin
cannot-
can't get too high because you're holding
It
on
has
to
to
it
be-
with that, so you need to monitor it no matter what.
But
And
I
any
like-
med, it's monitored.
I would usually, no, if they're well controlled, there's nothing that should go on your for a moment. Like, I'm not gonna worry about it, but if they're intra-kidney issue,
Like dehydration, there's really,
right, we gotta be a little bit careful.
okay, so when you say there's multiple P waves, how do you tell the difference? Like, that's not a TU, that's a P wave. Like, how are you just kind of like,
You get used to that, that's practice. Okay. There's not a distinction flat line. So AFib, the line's always weaving. I don't ever get to a straight flat line.
right? And then with AFib, you would need to take a pulse for 5 minutes while
I
it's
said I don't know.
accurate.
First time.
This is how my brain works.
Almost
That's how
on
her
mine.
brain works. I wish I could.
Yes. Most, I would go at least 30 seconds. But